Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Today's program is part of our genetics series, a special collaboration between the Blum Center and the Center for Genomic Medicine at Mass General. Before we get started, I just want to go a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. I'll talk through in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Next, I would like to introduce you all to today's guest speaker. Joining us today, we have Elizabeth Fieg. Elizabeth is a senior genetic counselor in the Division of Genetics at Brigham Women's Hospital. She currently sees patients in endocrine genetics and in a pharmacogenomics clinic that she helped establish in 2018. Elizabeth is a member of the ClinGen Pharmacogenomics Working Group and currently serves on the advisory board for the All of Us Genetic Counseling Resource. She is also the site coordinator for the BWH Harvard Clinical Site of the Undiagnosed Disease Network and an adjunct assistant professor in the genetic counseling program at the MGH Institute of Health Professions. She joins us today to give a talk on pharmacogenomics, so please join me in welcoming Elizabeth.
So thank you again for having me today. I'm excited to talk a little bit about pharmacogenomics and what our genes can and can't tell us about precision medicine and personalized medicine. So I'm going to start with just going over pharmacogenomics kind of as a general concept, talk a little bit about the benefits and barriers to the clinical utility of pharmacogenomics, different resources that exist for patients and providers, and then talk a little bit about experiences from the pharmacogenomics clinic at Brigham and Women's Hospital. So starting with some overview of pharmacogenomics, this is a field that essentially is a response to the problem of variability in medication response. When the same medication is used for the same group of people, there will be varying responses seen. Some people will respond well to the medication and it will be effective in treating their symptoms. Other people will not respond to the medication. It won't benefit them or help control their symptoms. It won't do what it's supposed to do, essentially. Other people will not only not improve on the medication will actively cause problems for them. And both of these two reactions, the therapeutic failure and the toxicity, are examples of an adverse drug response. And this is a term that I'll be using throughout the talk. And so just to keep in mind that it refers to either a medication not working well, not doing what it's supposed to, and a medication causing negative side effects. Those are both considered adverse drug reactions. So pharmacogenomics as a field is really combining pharmacology, which is the study of the uses and effects of medications, with genomics, the study of genes and their functions. And you might hear pharmacogenetics or pharmacogenomics, genomics or genetics. Basically, they're referring to the same thing. Genetics is typically used for looking at individual genes, whereas genomics is kind of broader, looking at all of the genes. So I'll use pharmacogenomics in my talk today, but that's really looking at the same thing, kind of same concept as pharmacogenetics. And the idea of pharmacogenomics is to utilize genetic testing to help us predict and understand how genetic variation impacts drug metabolism, so that providers can choose medications that are going to be most likely to work for the patient and least likely to cause side effects. So we always want to be maximizing the therapeutic benefit and minimizing the therapeutic failure and/or toxicity. There are many genes that influence how somebody will metabolize, absorb, or respond to medications. And there are also multiple ways in which genetic variation influences drug response. So the first mechanism is pharmacokinetic, which is how the drug is processed by the body. Some genetic variants affect how quickly or how slowly the body breaks down a medication, or the ability to absorb, excrete, or transport the medication throughout the body, or the function of enzymes that are needed to activate the medication. Some medications enter the body in an already active form. They're able to do what they're supposed to do right away. And others, which is called a prodrug, are medications that need to be activated by an enzyme. So they enter the body in an inactive form, and then the role of the enzyme is to activate it. The second mechanism is pharmacodynamic, which is essentially what impact the drug has on the body. So the effect of a drug is determined by how that drug binds with a receptor, which might be influenced by genetic variants, or genetic variants could predispose somebody to hypersensitivity or an immune-mediated response to the medication. And these can be very significant and potentially fatal in some cases, such as is the case with some severe cutaneous adverse reactions or things like Stevens-Johnson syndrome, which can be very, very severe. So this slide is showing 2 copies of the CYP2D6 gene. And everybody has 2 copies of every gene in our bodies, one that's inherited from one parent and one that's inherited from the other parent. And CYP2D6 is a very important gene in pharmacogenomics. This gene codes for the cytochrome P450 enzyme, one in particular, CYP2D6. And this gene is involved in metabolizing 60% of all medications. So again, everybody has 2 copies of every gene, and the copy of the gene with a specific variant on it is called an allele. And together, the combination of alleles is used to determine somebody's expected activity level of that enzyme. So in this sense, the genotype is used to predict phenotype, which for some pharmacokinetic genes is characterized by enzyme activity and metabolizer status. So this metabolizer status correlates to enzyme activity score and function, which either informs how quickly or slowly the body breaks down a medication, or how much enzyme is able to activate the medication if it's entering the body in an inactive form. So in this slide, someone who has 1 copy of the CYP2D6 gene with predicted normal function, which is the star1 allele, and 1 copy of the CYP2D6 gene with no function, which is the star4 allele, together, these alleles would cause somebody to be an intermediate metabolizer. And that just means that they would have slightly lower enzyme activity than a normal metabolizer. If somebody had, maybe 2 copies of a variant in the CYP2D6 gene that had lower decreased function, they might be a poor metabolizer, which means lower enzyme activity level than an intermediate metabolizer, and certainly compared to the normal. And some variants can increase the activity level of an enzyme, in which case somebody might be a rapid metabolizer or even an ultra-rapid metabolizer. So next we'll get into some of the benefits and some of the barriers to clinical implementation of pharmacogenomics. So really, when we're using pharmacogenomic information, that can be used to inform drug selection and dosing in a way that has the potential to improve clinical outcomes in a variety of different ways. So one is just minimizing the adverse side effects and treatment failures for patients. We know that adverse drug reactions are unfortunately very common. Between 40 to 70% of patients will experience some degree of adverse drug reaction. And about half of these are related to the recommended or kind of standard starting dose of a medication. So even going in with just the standard dosing prescribing, about half of patients are going to have some issue with that medication. So we know the same dose doesn't work the same in everybody. This can also really help save time for patients and generally cut down on costs. In genetics, we talk a lot about the diagnostic odyssey, the kind of journey of finding a diagnosis and answer for somebody's medical problems. And in pharmacogenomics, it's the therapeutic odyssey. It's that journey of finding a medication that will work well for somebody or do what it's supposed to do. It can take 6 to 12 weeks to assess and kind of realize the benefits or full potential of a medication. And that's a really long time for somebody to be taking a medication and their doctor's just kind of waiting and seeing. Is this going to help? We have to give it a chance, have to build up the levels enough in the bloodstream to really say if it's working or not before we try something different. And that's a long time if it ends up not working for somebody to have their symptoms just not controlled and not seeing any benefit to medication. So understandably, patients want to get better and have their symptoms controlled as soon as possible. And anything we can do to kind of cut down on that waiting process is a good thing for everybody involved. And it also is a good thing in terms of healthcare costs overall. Adverse drug reactions are a really significant burden and huge cost to the healthcare system. They account for up to 2/3 of drug-related hospital admissions and have high morbidity and mortality rates associated. So kind of on all levels, cutting down on this is a good thing for everybody involved. And then it can be hard to study this one, but I think at least anecdotally or kind of intuitively, it makes sense to me that having providers going above and beyond to try to avoid adverse drug reactions for their patient, or take the medication concerns or history of sensitivities that a patient might have experienced seriously, and trying to use all possible resources and options to make more personalized and more informed decisions. It seems like that could really help facilitate trust with a patient and provider and just improve their relationship, which I think ultimately could help improve patient compliance or medication adherence, and just the likelihood that someone is going to take something in the way that their doctor asked them to and prescribed for them. And really the trial and error process is again, a lot. It's a lot for everybody to go through. And so being able to reduce any of the guesswork involved in prescribing is a good thing. And pharmacogenomic test results might just be the difference to help a provider choose between what would otherwise be pretty therapeutic equals. There might be results that could help kind of push one up in terms of something that might be more likely to work. Or maybe we have a reason why the other one wouldn't work quite as well. I think, patients don't fail medications, medications fail patients. And so it's important for healthcare providers to really try to use all possible tools and resources to help patients access the most effective treatment as possible. So great potential benefit, but there are also some barriers. One just being that the clinical success of pharmacogenomics really depends on the ability of healthcare providers to appropriately interpret and utilize pharmacogenomic data. The results of pharmacogenomic testing aren't useful unless we know what they mean clinically, but they're also not useful unless we know how to apply them clinically. And we know that there's a lack of confidence, familiarity, and experience among healthcare providers of all kinds with pharmacogenomics. They might not have seen this come up in clinic before. They might not be familiar with how to order the testing, what labs do this testing, how to interpret the results, or how to apply the results. And specialists and primary care doctors already have a lot that they learn in training and that they need to be covering and addressing during what are pretty short patient appointments. So there just isn't time to learn and cover everything. And there's definitely a need for more resources to help educate and empower providers to be able to incorporate pharmacogenomics into clinical care and have the tools to do so effectively. Reimbursement and insurance coverage is always a relevant issue and barrier with genetic testing, unfortunately. And it's not an exception in pharmacogenomics. There are definitely efforts to help demonstrate cost effectiveness of pharmacogenomic testing in various settings. But even once there's more data available for that, it takes a long time for insurers to catch up and develop policies that reflect the research and demonstrated utility of pharmacogenomic testing. So, often I focus more on finding labs or ordering testing from labs that have accessible out-of-pocket costs for patients, or patient-friendly billing policies that will help keep costs capped or reduce costs for patients, as opposed to just relying on insurance coverage, since that's just not always realistic or possible. And then another one is having incorporation of pharmacogenomic test results into the electronic medical record or health system. And this is really key for clinical implementation and successful utilization of pharmacogenomics. There needs to be a system where the results are kind of live inside the medical record for patients and would be interactive for medical providers that might go to prescribe a medication, for example. We can't just rely on providers looking for results in a chart or looking for a scanned document in the media tab. There should be, kind of interactive system. This is just an example of a pop-up that could show up if a provider went to go prescribe a type of medication called thiopurines. And there would, maybe be an alert that shows that there's either, not a pharmacogenomic test result, in which case maybe a provider would want to consider ordering TPMT gene testing for the patient before prescribing thiopurines, since those test results could potentially inform that medication management decision. Or if there are results in the system, there could be a pop-up that would show, depending on what the results are. Maybe it would be that there would be no changes to medication prescribing, or if there would, having some system to let a provider know in an active way. So that's definitely, I think, important for just helping set up everybody for success in terms of how we are maximizing the potential benefit of pharmacogenomics and pharmacogenomic testing. So these genetic variants are very, very common in the general population. This is in contrast to kind of typical medical genetic testing or diagnostic testing, where we're looking at very rare genetic disorders. Pharmacogenomic testing, we're not looking for rare genotypes. We're looking for very common genetic variants in the general population. So essentially, everybody who has this testing is going to have at least one actionable result come back. And I'm using clinically actionable here to refer to variants with published guidelines by professional organizations that say and detail exactly how the result will be relevant and should be used to consider clinical changes in either medication selection or medication dosing. So whether or not the results would impact a patient's medication at the time of testing, there are definitely broad clinical indications for the medications that could be impacted or could have relevant genetic variants that might be made over somebody's lifetime. So just knowing that a result, at least one result, we would expect to come back for somebody, and it could be multiple. So in that vein, results are common, and we expect at least one positive result, but there are still limitations in how useful that result might actually be. It might be that, the result just will never be relevant for a patient if they never need to go on the specific medication that's associated with that gene result. Or maybe the patient has already been on that medication and they already had an adverse response, in which case testing found an answer already, but not in a way that helped us avoid it. If you're ordering relatively broad testing, it is more likely that there could be a result that would be useful in the future, but it's still not a guarantee. So definitely an overall limitation. And we know that there are non-genetic factors that also impact the effectiveness of pharmacogenomics. We shouldn't just use the genetic results in isolation. We always need to be considering other factors. There are things like diet, age, underlying medical problems, and other medications somebody might be taking. Those can all influence specific medication response. And sometimes those other factors might be more significant than the genetics, in which case, we might see a reaction different than what we would predict based just on the pharmacogenomic test results. And that's called phenoconversion, when we see something that doesn't line up with what we would have expected just based on the genetic variant that we found or that we knew to look for. So ultimately, pharmacogenomics is really just one piece of the puzzle and one clinical tool that providers can use to potentially make more informed medication decisions. And then lastly, a negative result doesn't rule out that there could be a relevant genetic variant for a patient. A negative result might also be called a wild type result or show up as star one on a report. And what this means is basically just the absence of a genetic variant that would be known to impact gene function and thus the function of that enzyme that it codes for. So it doesn't mean that there, is somebody would definitely have a quote normal response to medication or not experience adverse reactions. There could still be another genetic variant in that gene that could affect the gene, could affect medication response. But that variant might just be one that we don't know about right now in 2024. And so it's not available for genetic testing. Pharmacogenomic testing is typically looking for specific variants in the gene that are known to affect the function of the gene. But the testing isn't usually sequencing the entire gene. So the test it therefore wouldn't detect rare variants in the gene that might be present, but just aren't well understood yet and haven't been identified or studied or made available for clinical testing. And this is especially a limitation in patients who are from different backgrounds and represent more diverse patient populations. Most of the research in pharmacogenomics has been done in patients who are of European ancestry, which means that if for a patient who is not European, they might be less likely to have a positive result from testing because they might carry more rare genetic variants in that pharmacogenomic gene that haven't been as well studied. There are definitely efforts to have more inclusive research that better represents people of all backgrounds, but this is still definitely a limitation and a huge problem in genetics as a whole. And there are other ways in which the field of pharmacogenomics is limited by ancestry and race. And I think it's important to acknowledge the role of racism in the field and systemic racism and oppression in healthcare as a whole. We need to be considering who is accessing and who is benefiting from pharmacogenomics, since this isn't testing ordered or a referral offered to all patients. So a provider might order pharmacogenomic testing for a patient based on that patient's race, ethnicity, or ancestry. And that might be on the assumption that this is a cost-effective strategy. It's certainly true that the frequency of specific genetic variants or alleles can vary across frequency of across different population groups. And so testing higher risk population groups, isn't an effective strategy if we aren't accurately and correctly identifying those high risk groups. We need to start with just considering the terms race, ethnicity, and ancestry. These are often used interchangeably, but these refer to very different things. So in general, race and ethnicity refer to social but not biological categories. Race is a label that refers to the color of one's skin and is a social construct. Ethnicity might be used to refer to culture or describe one's community, traditions, language, lifestyle, diet, and general values. And ancestry could be used to describe genetic ancestry as a biological trait based on genetic variants that result from reproductive isolation and population drift. So when we use these terms, we just need to also consider the concept of admixture in ancestry especially. And admixture basically reflects lineage from different biogeographical groups. So for example, somebody who has ancestry from Africa and Europe is not just African or just European, they are a mix of both. And given that most people are not just one ancestral group, they might have heritage and ancestry across different parts of the world, it becomes problematic when genetics relies too heavily on single ancestry labels and factors this into clinical decisions. A genetic variant might be more common in particular population groups, but if it's clinically actionable in anyone, it's better to just look for that variant in everyone rather than assigning people as being just from one ancestry group and deciding, that based on frequency of variants and across different populations, one group is high risk and one group isn't. My approach and our approach in the Brigham Clinic is that it's better to do panel testing for everyone than order more limited testing based on the assumed race or ancestry of a patient. So there are different benefits to ordering broad preemptive pharmacogenomic testing. We'll go over some of those benefits here. The biggest benefit is just having broader utility and likelihood that a result could be clinically informative and impactful for a patient. So the earlier we do testing in terms of somebody's lifetime or medications that they've been taking, the more likely it is that results could be used prior to initiating a new medication for a patient. So this is the idea of preemptive testing. And this means that we could potentially prevent an adverse drug reaction or start a patient on just the ideal and most likely to be therapeutic medication or dosage of a medication at the onset instead of kind of having to go through the trial and error process or, start low, go slow process that could otherwise delay, getting to that right treatment regimen more effectively and more quickly. And when we're doing broader testing, we're ideally including genes that have clinical guidelines and labeling indications across different clinical areas. And, when we're testing more genes in that process, it's just more likely that a patient could get back results for genes that, could be relevant over their lifetime for different clinical areas or medication groups. So just makes it more likely that at least some of those findings could be impactful for that patient, at some point during their lifetime. And there are actionable gene drug pairs across a pretty broad range of clinical areas that cover medications that could be relevant at different time points for a patient. So this includes medications used to treat certain types of cancer, different psychiatric conditions like anxiety or depression, some seizure disorders and anti-seizure medications, GI problems, chronic pain, or pain medications and anesthesia used in the context of surgery, and cardiac conditions like high cholesterol. So while there are actionable results from pharmacogenomic testing that can cover a range of different clinical areas, we don't have guidelines for every medication that exists, either for those specific conditions or just in general. Pharmacogenomic testing will not give people a roadmap guide for all of their medication needs. There are many medications that do not have clinical pharmacogenomic guidelines available. And if a medication doesn't have a clinical guideline available, there's no genetic testing that would be able to guide any management decisions for that medication. So I think panel testing is generally the best approach, but other providers might be inclined to order more indication-based testing for a handful of genes or even just one gene relevant to a specific clinical question or specific medication that provider is considering for a patient. This testing might also be more likely to be covered by insurance than a larger panel, but the more limited testing is in terms of having limited testing of the genes being covered. I'd say the more limited the clinical utility will be in terms of kind of broad medication guidance. But at the same time, there's a limit to how broad testing should be and how many genes should be ordered. Our clinical team at Brigham is currently ordering a panel of about 16 genes as of March 2024. So, there should be some caution, I would say, for patients or providers that are considering a panel much larger than 16 genes. There won't be current clinical utility or much utility from ordering a large panel of many more genes than that. It's possible that some of these genes would eventually be found to have a clinically significant impact on medication response, but they shouldn't be used to guide or inform any medication management decisions until there is a published clinical guideline to say exactly how and when that result will be used. And I want to address one gene in particular, since this comes up relatively frequently in genetics and pharmacogenomics. And this gene is called MTHFR. And so the MTHFR gene codes for the MTHFR enzyme. And there are two very common variants in the MTHFR gene that are typically tested if somebody has MTHFR testing. And these variants are C677T and A1298C. And those names just refer to where in the gene those variants are located and what impact they have at that position in the gene. And again, these are very, very common variants in the general population. It is not rare for somebody to have one copy of these variants, one copy of each of these variants, or two copies of one of these variants. In general, the MTHFR enzyme is responsible for helping regulate levels of homocysteine in the blood, and having lower levels of MTHFR enzyme activity can lead to having slightly higher levels of homocysteine, or something called hyperhomocysteinemia. And this is itself pretty common. About 5 to 7% of the general population has mildly elevated homocysteine levels. And having mildly high levels of homocysteine is considered a risk factor, has been associated as being a risk factor for certain health problems, such as stroke and heart disease. So in general, for MTHFR, there's kind of this indirect association with having MTHFR gene variants that could affect the activity of the enzyme, having elevated homocysteine levels, and then having certain risk for certain medical problems, but it isn't the MTHFR gene variants themselves that are directly causing a problem. The research on the association between MTHFR and various medical problems is pretty controversial, I would say, in medicine in general and especially in genetics. But there's not currently any conclusive scientific evidence showing that common genetic variants in the MTHFR gene cause medical problems. There are also no clinical pharmacogenomic guidelines for MTHFR and any specific medications. So this is ultimately not a gene with any utility or clinical actionability right now in pharmacogenomics. And as you can see here on this slide, this is just a visual aid that I made. And being a carrier of either MTHFR variant is not associated with any medical problems. Neither is having one copy of each variant or two copies of the A1298C variant. The only MTHFR genotype with any associated medical risks is if somebody has two copies of, or is homozygous for, the C677T variant, and they have elevated levels of homocysteine. And in that case, they are potentially at an increased risk for blood clots, stroke, miscarriage, and pregnancies affected by a type of birth defect called neural tube defects. And given how often MTHFR testing is misused and misunderstood, a number of professional organizations have issued statements and/or recommendations suggesting that MTHFR testing not be ordered for patients, just given that the results really don't have clinical utility. There are many patients and some providers who feel strongly that MTHFR is relevant to medical problems. And there is a lot of information online and a lot of websites that kind of encourage this belief and this theory and suggest that, the medical establishment and kind of Western medicine is wrong about MTHFR. I generally am on the belief that I don't think we can say for sure that MTHFR isn't related to other medical problems. There isn't evidence to say right now that it is, but anything is possible, and there's a lot that we don't know in medicine. I do think it's important for people to be cautious and a little wary of sources or websites that link MTHFR to various medical problems, especially when these websites or sources are selling nutritional supplements designed to address methylation defects and MTHFR function. If somebody benefits from taking MTHFR-based nutritional supplements, that's great. I want people to feel their best and be at their best. There's some risk with nutritional supplements because they aren't regulated the same way that prescription medications are. So you don't always know exactly what's in them. But a bigger concern, I think, is just the cost involved. There are many people out there who are unfortunately looking to make money and might have exploitative or predatory approaches to other people who have very real chronic medical problems and are looking for an answer and are looking for help. So in general, I caution people to be wary of MTHFR nutritional supplements, since these might not ultimately help with symptoms and they can be a significant out-of-pocket cost. So next, we're going to talk a little bit about some resources in pharmacogenomics that patients or providers might be interested in. And there are three main resources for all things pharmacogenomic. So the first is the FDA, the Food and Drug Administration, and the FDA regulates pharmacogenomic information that's found in some drug labeling. The labeling might include specific actions to be taken, and some medications have boxed warnings that refer to pharmacogenomics, and that's kind of the most serious warning for the FDA in drugs that carry risk of severe adverse reactions that could be linked or informed by pharmacogenomic testing. The next resource, PharmGKB, was formed in 2000 and is a comprehensive online resource that collects, curates, and disseminates information and knowledge about the impact of human genetic variation on drug response. So it's kind of like the Google of pharmacogenomics in that it includes clinical and research information about a given gene and an associated drug response. And then lastly, CPIC is the Clinical Pharmacogenetics Implementation Consortium. CPIC is funded by the National Institute of Health, and it was formed in 2009 to provide international consensus guidelines on pharmacogenomics. So these are published guidelines that are actionable, peer-reviewed, evidence-based, and freely available through their website. CPIC guidelines don't provide guidance on whether a test should be ordered or not for a patient, but rather are designed to help clinicians, who have results in hand, understand how those test results should be used or could be used to optimize drug therapy. So CPIC is what our clinical team at Brigham uses as kind of the highest level of evidence to determine, what pharmacogenomic test results are clinically actionable and interpret how the result could be potentially used by providers to consider changes in medication selection and or dosing. There's a lot of overlap between FDA and CPIC and some other groups. But that's just kind of the first line resort that we use for looking up a gene and drug medication association. We're just looking into how a result could be useful for a patient. And as a first step, I often just go to CPIC if there's a specific medication that a patient is interested in or something that they're concerned about. I'll just go to the CPIC website and see if there's a clinical guideline that exists for a given medication. If there isn't a guideline that exists, that essentially means that pharmacogenomic testing will not be clinically informative for that medication. There probably is a gene or maybe multiple genes that would be related to that medication and how it's processed in the body, but that doesn't make pharmacogenomic testing clinically informative. There are many things that, are genetic or have genetic components, but that doesn't mean that genetic testing has clinical utility or tells us what to do about something being genetic. So let's say that we want to look up a medication to see if there are clinical guidelines that would be informative for somebody. I can just use the search function on the CPIC website and enter in the medication of interest. So let's say that I have high cholesterol and my doctor is considering starting me on a statin, which is a commonly used medication to help lower cholesterol levels. I could either just type in statin or type in the specific statin that my doctor wants to try me on, which let's say that this is simvastatin, also called Zocor. So when I type in simvastatin, you can see that there is a guideline that pops up for statins, and the drug list here specifically includes simvastatin. It's the last medication on that list. When using CPIC, be sure to only type in generic medication names, since brand names won't pull up any information. So we know that there's a guideline for simvastatin, but you'll see here that nothing shows up when I search for Zocor, which is the brand name for simvastatin. So going back to the simvastatin search page, if I click on the guideline text here, that would take me to the specific guideline published by CPIC for statins and the genes associated with statin response. And in this case, the CPIC guideline for simvastatin indicates that pharmacogenomic testing could be helpful in identifying patients who are at increased risk to develop muscle pain after taking statins, which is called statin-induced myopathy. If someone has a genetic variant that increases their risk for statin-induced myopathy, their doctor could consider pharmacogenomic testing and then could review the CPIC guideline to see how a positive or informative result might be applied in that setting or how it might be appropriate to use in order to identify the best type of statin to try of the ones listed here, and maybe what dosage would be best to start that patient on to try and prevent or avoid them from having that reaction of statin-induced myopathy or the muscle pains. So it's important to remember that if someone has an actionable variant in a gene that has a CPIC guideline for one or more medication, that doesn't mean that they shouldn't take medications associated with that genetic result. It might be that some medications aren't indicated as the best starting option, but it might be that there's just a change indicated to the starting dosage. So maybe it's best to have a higher starting dose or a lower starting dose than what would otherwise be the standard starting point for a provider to prescribe. So the existence of a guideline isn't a bad thing. It doesn't mean that the medication should be avoided. It just means that there's extra information available for that medication to make more informed prescribing decisions based on that patient's individual genetic test result. So if you type something in or have a result that was positive in one of these genes, that doesn't mean that all of the drugs listed here are bad or that you can't take them. Some of these might be the best medication to take, and now your doctor has a better sense of which medication to choose and which dosage to start you on. So let's look at an example of just how complex pharmacogenomic results can be and how important it is to have an experienced medical professional involved in the process of interpreting and applying the results of testing. So this is a made-up patient example, but Marco had pharmacogenomic testing done through a direct-to-consumer test kit that he got for Christmas from his partner. Marco is in pretty good health. He has a therapist that he meets with weekly for mild depression, but he's not taking any medications at this time. He has occasional heartburn, which is also called gastroesophageal reflux disease, but no other medical problems. Marco has a family history of some paternal relatives with heart disease, including strokes. His father has coronary artery disease and has needed 7 stents over the years, which is a surgical procedure that places a small tube inside the artery to help it stay open and restore blood flow. So Marco shares the results of prior pharmacogenomic testing with his primary care doctor, and the testing included analysis of 3 genes. Marco is especially interested in what his CYP2C19 gene result means, which is the one in the blue box up here. He tells his PCP that he's taken omeprazole, brand name Prilosec, which is listed on the report here, in the past for his heartburn. And he's also pretty sure that his dad has been given clopidogrel, brand name Plavix, which is also listed on this report here. So Marco's wondering, what do these results mean for me? So I'm going to focus on how the CYP2C19 result is relevant for clopidogrel and omeprazole specifically, though there are other medications that could be impacted by this result that were listed on the previous slide, or should have been listed on the previous slide. So Marco was found to have a star2, star1 CYP2C19 result. And this is associated with being an intermediate metabolizer, which means that Marco has slightly lower activity of the CYP2C19 enzyme than a normal metabolizer status. So that's relevant for both of these medications, clopidogrel and omeprazole, but in different ways. So clopidogrel is a medication that enters the body in an inactive form, and it's activated by the CYP2C19 enzyme. Whereas omeprazole is a medication that enters the body in an already active form, and it's broken down by the CYP2C19 enzyme. So for somebody who's an intermediate metabolizer and has slightly lower activity of this enzyme, that means that they're not able to fully activate clopidogrel. So it's not fully active in the body to do what it's supposed to do. And it means that somebody is going to break down omeprazole slower than expected. So the levels are going to build up higher in the body overall based on like a standard starting dosage. And so the really takeaway here, kind of the outcome here, is that clopidogrel is not going to be as effective in somebody. And clopidogrel is a very common medication given after a stent, for example, or in somebody who is at risk for strokes. So not indicated for Marco, but could have been, it sounds like, used for his dad. Clopidogrel is not going to be as effective, and this, potentially could be something that was inherited from Marco's dad, or maybe his dad has even lower enzyme activity and is a poor metabolizer. In which case, clopidogrel really shouldn't be used in somebody with lower activity, because if the medication isn't fully activated, it's not going to do what it's supposed to do. And for omeprazole, the levels in the blood are going to be higher than usual because it's not being broken down as quickly as it normally would be. And so the recommendation for omeprazole would actually be that the medication would work very well in somebody. There's no reason to think that it would be a problem, but somebody like Marco would be able to potentially take a lower dose of omeprazole in order to have therapeutic benefit. Because again, he's breaking it down a little bit slower, so the levels are going to be higher in the blood. And so he might be able to take lower levels of the medication and still see improvement in symptoms. And that's generally the ideal outcome. We want somebody to be taking as much of a medication as they need to control their symptoms, but no more than that. So kind of have, just as much as we need. And Marco might be able to get away with a lower dose than most people. Whereas again, for clopidogrel, the recommendation with the CPIC clinical guideline would be to not use the standard dose and really, try to use a different therapy altogether if that was indicated, if Marco were to develop different cardiovascular problems that would be treated with clopidogrel. So in general, definitely is a complicated process of interpreting and applying results. We know that the same result, the same gene could have very different recommendations for different medications that are associated with that gene. So just important to, be considering that and not just kind of applying everything in the same way. And especially, again, not having the approach of any medication that's linked to this result shouldn't be used. Again, for Marco, omeprazole could work very, very well in him. We just have more information to inform what dosage would be best for Marco. So avoiding that medication isn't the right answer. Whereas for clopidogrel, that would be the best approach, or potentially the best answer would be to avoid that medication. So really making sure that we're treating each medication association with the genetic result as an individual result that should be interpreted differently. We can't apply, the same approach to different medications for the same gene. And then really just being aware of different specialists and different resources for providers or patients who are interested in pharmacogenomics. And there are some across MGB, Master Enrolled Brigham, for patients who are interested in broad genetic testing for kind of overall health. They might be interested in an out-of-pocket kind of self-pay service like the preventive genomics clinics at Brigham or MGH. And another option that I'll talk more about for pharmacogenomics is the specialty pharmacogenomics clinic at Brigham and Women's Hospital. So get into that a little bit now. So this clinic is a collaborative practice involving a genetic counselor, which is myself, a primary care physician, and a clinical pharmacist with specialized training in pharmacogenomics. We see patients for virtual visit appointments and can order pharmacogenomic testing and or interpret and discuss existing results of prior pharmacogenomic testing. And this is assuming that testing was done fairly recently from a reputable lab with CLIA status, so clinical grade genetic testing. And as of March 2024, when I am giving this presentation, we are scheduling out very far, 8 or more months for new patient appointments. We're actively working on hiring new clinicians and adding new clinic sessions to reduce this wait time. But just to be transparent for anybody who might be interested in pursuing evaluation, there is currently a very long wait time. We have a cancellation list. And again, we're hoping to cut this down in the next few months just to get people seen sooner to make this more accessible as a service. So the telehealth video visits can be video or phone call. Institution and state policy requires that patients be physically located in Massachusetts at the time of visit, but they wouldn't be seen at Brigham and Women's Hospital unless they were already there for some reason or that was the preference. We do ask patients to complete a medication questionnaire with information about prior and current medications, just to help us have a more informed discussion about the potential benefits of pharmacogenomic testing and, of the medications that somebody has been on or is taking, which of those medications have those clinical guidelines where the test results could potentially explain an adverse reaction that somebody's had or give informative information about current medications that somebody's either taking or that their doctors are considering for them. The cost of the appointment itself is billed to insurance and typically covered. I've never heard of patients having issues with needing to pay for the appointment itself. This is a clinical service and a clinical appointment. There might be a out-of-pocket cost if somebody has like a copay for specialty medical appointments, but otherwise the appointment itself should be covered. The cost of genetic testing is not always covered. We would discuss that more in an appointment. And there are some options for patients to, have more accessible billing potentially, or, have $0 out of pocket estimated for Medicare and Medicaid patients. So at the first virtual visit appointment, we meet with patients to identify patient goals, provide some education, and set realistic expectations, as well as go over that medication questionnaire and some family history, and then ultimately discuss benefits, limitations. The patient would decide whether or not they want to pursue pharmacogenomic testing. If they do, we typically order testing for a panel of 16 or so genes, and a sample collection kit would be sent to the patient's home by the lab. That includes instructions on how to collect a sample. It's a cheek swab sample, as well as packaging materials needed to send in the sample to the lab. And then at the follow-up virtual visit, we would take an updated medication history if there have been any changes, review how the test results may or may not relate to somebody's current medications, or their history of medications. We summarize the results of testing in a clinic letter, and then we upload things into the electronic health record. So relevant, clinically actionable genotype results would be entered as either a problem in the problem list or as an allergy. If this is a kind of high impact, high stakes result, that could have a severe, potentially life-threatening complication. So in closing, I just want to end with some general considerations. The first being that it's important to just understand the limitations and approach pharmacogenomics with realistic expectations. Medication response is complex, and genetics, again, is one piece of the puzzle. We only have clinical guidelines available for some medications. So while this is a growing area, doing pharmacogenomic testing won't give somebody information about every medication that exists. Pharmacogenomic testing is not done in-house at MGB, at least not yet. So it's done at different outside commercial labs. Not all tests or all labs are the same. No one test or lab is perfect. So just being aware of, the type of lab that you're using, the type of billing policies that exist for patients, the number of genes included on testing, and really, try to avoid low evidence genes as well as labs that oversimplify the results of testing on the report. It's often nice or easy to look at a report that kind of neatly color codes results or buckets them into different categories. But unfortunately, interpreting the results just isn't that simple. As we've seen through this session, the results are complex to interpret and apply, and there are often different medication recommendations for any one result. So be kind of wary or careful of labs that seem to make it more simple or easy to apply or interpret the results than it really is. And really remember that a negative result doesn't mean that there's not a genetic variant present that could impact somebody's response to medication. A quote normal result doesn't mean that somebody will definitely respond, quote, normally to a medication. It just means that nothing was found that we can use to predict response to that medication. And again, there can be a lot of non-genetic factors that can also affect and influence medication response. The most important piece of information is always a patient's medication history. We can use pharmacogenomic results as a prediction, but medication history and how somebody has reacted is the reality. And for providers, just being, thoughtful or mindful or acknowledging the experiences that patients have had, and being compassionate. It can be very difficult to go through adverse reactions to medications, really scary, and really traumatizing to just have so many trial and error processes and so many medications not work. So understanding why somebody might be afraid of starting on new medications, or reluctant to be taking prescription medications. Trying to build trust and really address some of these concerns in that moment. And really, again, takes a village, being aware of different resources that exist, referring to pharmacists, referring to genetics resources is an important piece. And really using some of the resources that I outlined here, including CPIC, which again is something accessible and freely available to the public. So with that, I will close, and I think we have some time for questions and answers, but a huge acknowledgement and gratitude to Dr. Roseanne Donnelly and Dr. Ben Kerman, who both run the pharmacogenomics clinic with me at Brigham and Women's Hospital.
Thank you, Elizabeth. We are now at the end of the session. If you have any questions, feel free to enter them in the chat. We have a question regarding pharmacogenomics. Is it a field that's fairly new, or has it been studied for a while now?
Yeah, great question. So it's a field that I would say is fairly new in terms of the clinical implementation. Definitely, we've known that medication reaction has a strong genetic component for a long time, but actually being able to clinically test for genes that are, we understand well enough in terms of what medications they might relate to or what specific changes in a gene we should be looking for. That part I would say is relatively new and still very much growing, clearly has a long way to go. So clinics like this, I'd say there are not that many across the country, but they are relatively new, like within the last 10 years, I would say, or so.
Thank you. And when is it beneficial for a patient, whether it should be considered for them?
So I would say there is no, somebody being interested is enough. In our clinic, we see patients for any reason. We see self-referrals, for somebody who often the most impactful time to do testing is before somebody has been on a prescription medication. If somebody's already had reactions to a number of medications, we might be able to find an answer through pharmacogenomic testing for, why some of those happened, if it's a gene where we have those clinical guidelines that exist. And that can still be very meaningful for people. I think it can be very validating, very reassuring to have an answer for why they developed that adverse reaction. But it's not really giving us, information to avoid it. It already happened. And so in that sense, I think a preemptive testing model might be the most effective in some ways of, being able to use the results to avoid adverse reactions, get to the best medication quicker. But there's no wrong way or wrong time, I would say, to do this testing.
And for patients who are interested, would this be a conversation that they can have with their primary care provider or with a specialist?
That's a great question. I would say it depends really on the provider and the specialist. Some providers might have experience with this. They might have familiarity. They might even be willing to order it themselves. Others might not. There are also just different attitudes in the field as to, how useful this testing is. I think there, as I've hopefully highlighted, there definitely are limitations in pharmacogenomics. This is one factor that providers could consider in some settings, but it's not the end all be all. We would always defer to a prescribing provider in terms of the ultimate decision about what medication would be best for a patient, what dosage would be the best starting point. So I think it's a conversation that hopefully providers would at least be open to or open to considering. And definitely, our clinic, we're happy to see patients, but I definitely recognize that, it might not be something that providers themselves would want to order or kind of be the one leading the charge. But that's where hopefully, our clinical team can help support providers across MGB, at least, who are interested in incorporating this or making it available to patients who are interested.
Thank you. In follow-up to what you had just pointed out, you said you have a clinic over at Brigham Women's Hospital. For those who may be MGH patients joining today, do you know if there's a clinic within Mass General?
There's not one that's specifically for pharmacogenomics. There is a preventive genomics service. And my understanding is that pharmacogenomics might be kind of one piece of what they provide. That's generally designed for patients who are not kind of being referred or presenting with a specific medical problem. It's more kind of just a general interest in utilizing genetic information to, try to avoid medical problems or stay as healthy as possible. So I'm not aware of a pharmacogenomics specialty clinic like the one at Brigham, but definitely we're happy to see any Mass General patients. Again, it is a virtual visit, so you don't have to cross the river or travel to the other part of Boston. So hopefully an option for some patients who might be interested.
Thank you. So it looks like we're at time. Before we end today's session, do you have any final words you'd like to share with the audience, Elizabeth?
None other than, I think this is a growing area for sure. Still a lot of limitations, but definitely exciting to see growing potential and hopefully something that can still also have real-time benefits and value for patients and for providers.
Wonderful. Thank you so much for spending the hour with us, Elizabeth. This was very helpful.
Thank you for having me.
And for everyone who's tuned in today, thank you so much for joining us. As I had mentioned, today's session is being recorded. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you, everyone. Have a lovely rest of the day.